Hello, everyone. My name is Anna May Obo. I'm a fourth-year medical student at Michigan State College of Human Medicine, and I'm the Speaker of the House of Delegates for the Student National Medical Association. I want to welcome you all to our Sowing Seeds Specialty Series, and today we are doing our Combined Residency Program panel. This series is part of our Sowing Seeds program created by our national president, future Dr. Asase Obo, in collaboration with the Alumni and Multicultural Affairs National Committee. Throughout this year-long program, we will be continuing to provide resources on how to succeed as a pre-med and medical student, and we'll touch on everything from financial literacy to preparing for board exams and more, so please continue to stay tuned. Make sure that you're a national member so that you can continue to gain access to the things that we do throughout the year and just generally to stay in the know. So now I'd like to introduce our panelists, starting with my mentor, Dr. Lisa Lowery, the Medpedes Program Director at Michigan State College of Human Medicine.
Good evening. How's everyone?
Next, I'd like to bring on Dr. Wyborn Asawad, also known as Doc. He's a pediatrics psychiatry and adolescent psychiatry resident, triple boarded in the future. Welcome.
Good evening, everyone. Nice to be here.
Then I'd like to introduce Dr. Veronica Wright. She's an internal medicine psychiatry combined resident.
Good evening, everyone.
And Dr. Crystal Mora, an internal medicine pediatrics resident as well.
Hi, y'all.
I want to give you guys each a chance to kind of share your stories. And so I'd like to start first with, we'll start backwards. Dr. Mora.
Absolutely. Hi, everyone. My name is Crystal Nora. I am a current internal medicine and pediatrics resident here at Johns Hopkins. I am originally from the Texas area, was born in Dallas. I went to undergrad at the University of Texas at Austin and went to medical school at McGovern Medical School in UT Houston. So super excited to experience something outside of Texas. And one of the things that I'm super excited to talk to you all about is my decision to go Medpedes and why I'm really passionate about urban health and primary care. So look forward to speaking more towards that later.
Thank you. Dr. Wright.
Hi, everyone. I'm Veronica Wright. I'm originally from the Pacific Northwest area, Seattleite. Went to school up in the Pacific Northwest and went to medical school at Eastern Virginia Medical School in Norfolk, Virginia. Currently, I am an intern in the Internal Medicine Psychiatry Residency Program at Walter Reed, which is obviously an Army military treatment facility, aka just an Army hospital. But looking forward to talking to you guys about internal medicine psychiatry residency programs.
Thank you. Doc.
Hello, everyone. It's a pleasure to be here tonight. As mentioned, my name is Doc, full name Wyborn Aswad. I am a proud and true native Angelino, born and raised in Los Angeles, went to undergraduate at Stanford where I studied human biology and African American studies. And then I went to, for undergraduate, I was in the Combined Charles Drew UCLA program in Los Angeles, focusing on urban underserved. And now I have forsaken all things California, came to the East Coast. I'm a second-year resident in Brown in our triple board program. Very excited about the intersection of race, poverty, mental health, and physical health, particularly in children. So looking forward to being able to talk to you guys about that.
Thank you. And Dr. Lowery.
Good evening. My name is Lisa Lowery. I am originally from Grand Rapids, Michigan. I went to Michigan State for undergrad, then University of Michigan for medical school. Thought I was going to be a pediatrician, fell in love with combined internal medicine pediatrics. So I did my residency in internal medicine and pediatrics. Decided that I had a passion for young adults and adolescents and actually did my fellowship at Johns Hopkins. During that time, also got my master's in public health. Subsequently returned back here to Grand Rapids, Michigan, and I have been back over 16 years now. I am a clinician and an educator. I practice primary care for our our adolescents and young adults, as well as wear a lot of administrative hats, and most recently started at Michigan State College of Human Medicine as the Assistant Dean for Diversity and Cultural Initiatives. So I have a passion for education, mentoring, and still love the fact that I did Medpedes, and would be happy to share, and happy to be here this evening.
Thank you all so much. As you guys hear everyone's stories and their passions, there's so much intersectionality here, especially because these residency programs that they're coming from are combined. Please feel free to ask any questions at all that you might have. So first I want to start with the residents. Share your why for your program. And then also, how was the transition from being a medical student to joining a combined residency program? And we'll start with Doc.
Right. So for me, one of the things, I started medical school knowing that I was going to be a triple board resident. And one of the biggest reasons being is because, as I began to mention to you all earlier, my interest in working with youth who have been exposed to violence, who have particularly gang violence and the juvenile justice system. I think by way of just interesting sort of history is that the week prior to me matriculating into medical school was the same week that Khalif Browder committed suicide. And for those who are unaware, he was a teen who was wrongfully accused and spent 2.5 years in Rikers State Prison in New York. For me, growing up in South Central Los Angeles, there was this very evident, obvious sort of social issues that you see are palpable, that when you go into college, you talk about them and they're these like really abstract things, but when you have this sort of lived connection to it, it feels a lot different. And so when we start talking about trauma, and when we start talking about adverse childhood experiences, those were some things that I were able to see, and knowing that we need to like do better in terms of just a medical establishment to be able to connect the dots with these issues. So for me, I saw the best way of being able to do that was to not only address the physical health aspects, but the mental health aspects of it, which really led me into wanting to be a triple board resident. And I would say that had been the foundational spark. And since coming into residency, it's been one of the things that I have kind of kept near to my heart. I really came to Brown because of our program director's interest in research in juvenile justice, youth justice system involved youth. In addition to that, though, just being able to be in the space where Providence, surprisingly, is a very diverse place. A lot of folks from throughout the African diaspora call this city home, and just being able to look at sort of these vestiges of, frankly, of racism and white supremacy that have caused just turmoil and traumas to Black people, brown people, indigenous folks. So just being able to address these passions that I have, in addressing these sort of historical wrongs, it's been something that I've been able to sort of use my career in medicine as a means for social justice. And just to answer that question about the transition, I mean, I would say that it's been wonderful to be in a program that's very clear about how we go through our different training portions. I think that's one thing unique about Triple Board, at least my program, that we do a very concrete, here's our 1.5 years in pediatrics, here's our 1.5 years in psychiatry, here's our year in child psychiatry, and then in our 5th year, we kind of split the time going back and forth between child psychiatry and pediatrics. But all that to say, right now I'm still in the bulk of my pediatrics training, and it's allowing me to really crystallize and see myself as a pediatrician. I forget that sometimes I will be a psychiatrist, but in a couple of months that will be clear to me that that's also part of my training. But that's my why, and that's been my transition.
Thank you so much, and thank you for really delving into a lot of really core things that we have continued to talk about, especially in the current zeitgeist. Thank you. I appreciate that. How about Dr. Mora?
So I always knew that I wanted to do primary care. I think it was pretty evident when I first got into medical school. I'm really interested, much like previously said, in social justice and thinking about how people can live their best lives and what it means to live a life that's really fulfilling, and you have access and the ability to do all the things that you want to do. And I only thought there was really one way to do primary care. I didn't really know about Medpedes when I was applying into medical school. And when I got to med school, people kept saying Medpedes this and Medpedes that, I was confused. I was like, are they just trying to say pediatric? Like, what is this? Both of them, they're combined. It's really confusing. But as I did more research in my program at my home school, fortunately had a program where I got to really learn about what Medpedes was, all the different ways that you can apply Medpedes and going into the future. So it was really encouraging to think, okay, like there are all these different opportunities and pathways to what you can do as a Medpedes physician, but I was also reassured that you can be a really strong primary care physician with a really great training in medicine and pediatrics. And that's one of the reasons why I love my program here at Hopkins. It's focused on urban health. It's focused on primary care. My electives are aligned in a way that allow me to try to be that practitioner that I know I want to be in the future.
Thank you so much. Yeah, I didn't know about Medpedes until April. Okay. Dr. Wright.
Hi, guys. So I went into medical school initially thinking that I was going to do infectious disease, mostly because a lot of my experiences prior to medical school in terms of like volunteering has been with HIV population. So initially went in thinking kind of like the trajectory would be internal medicine and then infectious disease. Certainly psychiatry is not ever like kind of on the radar before like clinical rotations. I would say during my third year rotation, that's when it kind of got a little bit more like consideration in terms of like career goals. I had my psychiatry rotation before my internal medicine rotation and found that it was something that was a little bit more organic for me than I thought it would be. And it was something that was really enjoyable for me. So this was actually in the midst of having general surgery as the rotation prior to that. So I was like possibly having some kind of like imposter syndrome during my general surgery rotation. And I kind of wanted to like put psychiatry, a little bit lower down on the consideration list, just recognizing that anything after general surgery would have looked good to me at that point. So I had my internal medicine rotation, I think about 2 rotations after psychiatry, and internal medicine was exactly what I thought it would be. Really enjoyable, very intellectual, very like diagnostic schema and like refining illness scripts, which are things that I've already enjoyed for most of like my medical career up to that point, specifically in like first year and second year when you're kind of building those skills. But that caused a little bit of like internal strife for me because I was trying to figure out like, okay, so I like internal medicine and I'm particularly like attracted to working with patients that tend to have really complicated like psychosocial situations. But psychiatry seems to address that as well. I was not aware of what med psych was prior to probably like, I think like halfway through my internal medicine rotation. I talked to my psychiatry mentor at that time, and he was the one who kind of put the idea in my head of like, oh, maybe you should think about doing like a 5-year residency program, which I was completely against once I heard it was 5 years. But as I went further along through my 3rd year and then also into my 4th year, got a couple of more experiences that kind of reaffirmed that med psych was it for me. I tend to be more interested in patient populations that tend to be considered like the complicated patients. And that's usually because of the psychosocial factors that they walk in the door with. And I do think that psychiatry training itself teaches you to look at a patient more holistically, look at the psychosocial and the mental health factors that complicate like patient outcomes when it comes to chronic medical conditions. Yeah. Hence, I ended up in an internal medicine psychiatry residency program that's 5 years long. as opposed to like a 3-year-long internal medicine residency. The transition itself, I think, is kind of interesting. I would say that probably my mindset going into intern year was that I was just going to like try to keep my head above water, which I think is everybody's, initial inclination of what it's going to be like. And what kind of surprised me wasn't that the medical side of things was difficult. I think we naturally kind of fall into what we already are comfortable with. But the difficulty of the intern year itself was more along the lines of learning how to work within the system that we're supposed to be operating in, like learning how to admit somebody and put in orders, like how to order a chest x-ray, how do I actually put in an NG tube and things like that. So I think those kind of like core learning how to be a doctor things have been something that I'm trying to get more accustomed to, and just learning to be more gracious to myself about learning how to do those things in the first place. In regards to like doing an actual combined residency in my intern year, my schedule itself is kind of set up in a way that I kind of flip back and forth in between internal medicine and psychiatry rotations, which I think is a good thing. Kind of trains me to kind of like be quick on transitioning my mind on like what I should be focusing on, how to do a mental status exam and things like that. But on the flip side of that, I think it probably is also teaching me to learn how to think simultaneously in both an internal medicine and a psychiatry way for all of the patients that I see, regardless if I'm on a medicine rotation or a psychiatry rotation.
Thank you. We do have a question. Dr. Lowery, because you kind of already shared a bit of your path already, I do want to ask you now, how has COVID-19 affected your experience, especially from a practicing standpoint and from an administrative standpoint as well?
Wow. From administrative standpoint, I remember it was a Friday, March the 13th, and I believe that was the Friday, and it all kind of hit the fan. And actually, that Sunday was probably the worst day, and we spent hours on calls. And literally talking about being nimble, you'd be on a call at noon and then no one would have the answer. They would give you the answer at 2 and then the answer to the question would change at 5. And so really kind of balancing that one from a practice, because I also care for 4 practices, but also taking care of my learners. So what are we going to do with our medical students? What are we going to do with our residents? Who's going to be in, out? And so really navigating within a team. And you just had to really become comfortable with, I don't know. I'm not sure. We're waiting and seeing, and really having those conversations. And it changed. I think it's still changing. Because I'm primary outpatient, we went to a model where like only one provider was in the office. And I actually opted for most of the time to come in because I don't have little kids and my 2 partners have kids at home. And so I was like, okay, I can come in more than you. And then we went all virtual. And so really navigating that with the staff. And the other thing is really dealing with the fears of your colleagues, so people are concerned about, if I come to work, am I going to get sick? And everybody was worrying, how, if, I'm an outpatient doc, am I going to be called up to be, work in the MICU? I mean, so there was a lot of, nurturing of a lot of fears. And then also, what are we doing with our learners and how you navigate that? Because I went from having 3 learners rotating with me to saying, okay, you're going to go home. And then how I'm still going to have you navigate this required rotation. And we're still learning, and it's been just a gradual process. Even to this, couple weeks ago, we went from everybody wearing masks to everybody wearing masks, goggles, and face shields, even in the outpatient setting. So, and then how do we bring our learners back, especially for our medical students? And I know Anime was witness to this. How do we sent you home? Now, how do we bring you back and bring you back in a safe manner? So it is very, I'm not saying it was, it is very complicated. We're actually we're doing virtual orientation with our first years now. So a first year I'm like a first year medical students. And then like I shared, I think earlier before the meeting, just how the interview season has totally changed. And so doing virtual interviews is going to be a new way of life. And so it's, I think someone mentioned early being dynamic. I think the people on this call or meeting, actually, because we chose combined residencies, we are nothing but nimble and not scared of change. So yeah, it's been interesting. It's been a steep learning curve.
Thank you so much.
Mm-hmm.
I believe we have a question coming up. Okay. So Dr. Wright, how competitive did you find I Am Psych? There are about 14 programs and about 28 spots nationwide. And a second question, basically, do you think that you're going to end up choosing either IM or Psych, or do you see yourself combining them?
I think that's a little bit hard of a question. I can tell you anecdotally what I've experienced has been that there are 14 programs nationwide, but there tends to be a very limited pool of people who are actually interested in doing a combined 5-year-long residency program. Anecdotally, I can say that most of the people that I know within like class of 2020, both at EBMS and also outside at different residencies now, obviously all matched. I wouldn't necessarily say that it's competitive in terms of step scores, but I would say different programs look for different things, particularly like the program that I ended up in. Oh, sorry, printer is going off. The program that I ended up going in, I think my co-interns and I are very different. I think a lot of residency programs look at applicants holistically, whether that be from like the lens of, you know, this person provides leadership skills, and, you know, this person is like a strong test taker, and this person, you know, just tends to be like a better fit vibe-wise with the other residents in the program. In terms of like your other question about most IM Psych people who end up practicing one or the other, I would actually say that's probably the opposite of what I've seen. If we're thinking about it in the lens of like how they're actually practicing, I would say, at least from most of like the med psych attendings that I'm aware of, both within the military and outside of the military, on paper, they probably say that they are doing one thing, but when you get into medicine, it's a lot about like different collateral things that you are also doing. I know that our program attending technically is, or sorry, our program director is technically a sleep medicine doctor, but he also attends on like the internal medicine clinic. So he is still doing medicine and he is still doing psychiatry. It's just a very interesting mix of the way that he actually practices it. I know there are some people who do consult liaison psychiatry that also do primary care internal medicine clinics. And then on the flip side, there are some people who are interested in internal medicine subspecialties. Like I'm personally interested in infectious disease, and you will never, ever find a place that's not looking for a psychologist or a psychiatrist, mostly because there are comorbid mental health disorders and there's just a lack of psychiatrists and psychologists in the United States. Other fields that are like that are like hemonc, rheumatology, and gastroenterology tends to be some subspecialties that are usually looking for psychiatrists and psychologists. So I personally think I will end up doing HIV care, and I'll probably end up doing HIV psychiatry. So I don't really see myself having to choose one or the other, but technically on paper, I would be doing infectious disease.
Thank you. We have another question for Dr. Lowery. So as a program director, how can an IMG increase their chances of matching into a combined residency? It's a good question. Thank you, Joyce.
Yeah, so I'm actually one of the associate program directors of our program, but I also think the biggest thing you can do is make yourself as competitive as possible. And I hate to say it, but it's still a numbers game as far as your board scores. So start with your board scores, study. I know soon step one is going to be pass fail, but then we'll be looking at step two numbers. So, but say, for example, you didn't get the best step score that you had hoped for. Also, we want well-rounded medical students. So I actually look for someone who's going to fit in my program, and that doesn't necessarily mean the smartest person. I want a hard worker. I want a dedicated worker. I also want someone who's committed to the combined life, whether it's psychiatry and internal medicine, Medpedes. I want someone who understands the philosophy of those programs and can work well with others. And then look at what kind of extracurricular opportunities that you have done. And when I'm speaking to, and I know Anime and other people at Michigan State have heard me, don't try to save the world all during medical school. You are a medical student. So, yes, be involved. Yes, have extracurricular activities. Yes, be involved in your community. But at the same time, you are a medical student, and so also focus on those academics. So but show yourself strong in leadership or research. And you don't have, like I said, you don't have to do everything, because we also don't want people just doing, I did a little research, I did a little this, did a little that. So but really find a couple areas and strengthen yourself in. But so I know it's a complicated answer, but board scores and some key areas, either extracurriculars like community service and or research. So that's what I would start with.
I'd also like to add, just from just anecdotally, that it is important for you to connect with your top programs right now. Mm-hmm. I think residents are interested, and you guys can also add this to our discussion. But residents are really interested in getting to know us and seeing who we are, if we're willing to make that effort and bridge that gap and kind of get over any insecurities along those lines. But also just remembering that you're dynamic in spite of, or along with your step score. So another question that we have that's kind of been floating around in the chat is how we as current applicants should approach the residency application cycle. And I think this is a question for everyone, because you all have a role to play in this application cycle. So I'd like to start with Doc.
Yes, of course, that's a really astute question, and thinking about how we've been saying that this year things are going to be different because of the social media, or rather the virtual aspect of how we'll be connecting with one another. And I think to that end, yeah, we've been talking a lot about fit, been talking about how folks get along with the residency. And I think that's just one thing that, we've been mindful of, at least in our program, and thinking about how to get in touch with you all as applicants, and understanding that you're going to have Zoom fatigue, understanding that things can be awkward. They're awkward enough in person, and then you add on this element of not even being physically in the same space. So I would just say that if at any point, be it you've been, sleuthing on the website and being like, oh, that's a resident I think I would want to connect with, or it's something that happens during whatever form of happy hour, social, virtual hangouts that we do, and you really think there's somebody who you thought that you would want to kind of talk to, go ahead and reach out to that person. I think residents who are being proactive to be available and make ourselves available during this season is because we really care. And I would say too, there are a lot of offices right now, I know throughout the country, at least in terms of our med school, our Minority House Staff Association, and our Office of Diversity and Multicultural Affairs have been being very, very cognizant about just how do we support underrepresented students coming into residency programs. So look out for those emails, look out for those things too. because people definitely do want to connect with you all and try to make it as genuine and real as
Thank
possible.
you. Dr. Wright.
Hey, I would echo a lot of what Doc just said. I think particularly if you're thinking about like the triple board option for like peds and psych and technically I guess child psych is a good one. Also, if you're thinking about family medicine psychiatry or internal medicine psychiatry combined residency programs, the Association of Medicine and Psychiatry is kind of the, I guess, like equivalent to like ACP or like APA for like specifically like medicine and psychiatry, whether that be like peds or internal medicine or family medicine and psychiatry. And they're a very good resource in terms of like finding mentors from different residency programs, putting you in contact with different residency programs. And I believe next month they're also having a virtual residency fair. So that would be something I would kind of like keep my eye out for. If you are not part of Association of Medicine and Psychiatry, I would sign up right now, especially since it's basically going to be close to interviewing season very soon.
Thank you. And Dr. Mora.
All right, so this is something that I'm thinking about constantly, something that I was thinking about a couple of months ago and actually wrote a paper with one of my former mentors who moved to a different school. But it's something that I think a lot of people are worried about is how do I get to know a program whenever we are in this virtual format, and how do I make sure that equity is preserved throughout this entire process? And so a couple of things that I would recommend for applicants who are just kind of virtually looking at programs is, one, recognize that at least at this stage, we're trying to get to know a program has not changed from previous years, right? So just removing the whole virtual interview process out of it, trying to figure out which programs are a good fit for you or which ones you're going to apply to has pretty much remained the same. All of us looked at the websites, all of us had to, reach out to individual residents and try to get in contact with program directors to learn more about programs. So be encouraged by that like trying to build your actual list of programs hasn't changed so much, just that you can't necessarily go and physically visit these places. And so I think making sure that you're looking at the website, looking at the face sheets, understanding, okay, who can I reach out to, just like Doc had already mentioned. And I think there's also space if you're interested. Medpedes, the National Medpedes Residency Association, has done a phenomenal job. Has hosted many, many webinars about what it's like to be a Medpedes applicant, what it's like to be a Medpedes physician, and what programs are looking for. If you go to the website, they should have all of the webinars that are pre-recorded that you can definitely access. One of the beautiful things about being in a combined residency program is that our community is much smaller. And so while there are thousands, it seems like, of internal medicine programs and pediatric programs, there's only about a handful, I'd say anywhere from like 80 or so Medpedes programs. And so it's actually a fairly small community, which means you really get the opportunity to think creatively and intentionally about the list that you want to build. And then I would also say use social media to your advantage. If you are someone who uses Med Twitter, I think that's a wonderful opportunity to engage with residents, to engage with programs. A lot of programs are doing their very best to try to show you what daily life looks like at their programs through their Instagram and through their Facebook. So definitely take advantage of that. But at the end of the day, realize that a lot of this is for you. So if you find yourself getting burned out, trying to go to all the happy hours, you can't go to another game night, you're just like, I just need an opportunity to take a break, do that. There'll be plenty of time to hop back onto Zoom when interviews come. But this phase right now is just about you data gathering, figuring out what programs would be a good fit for me, talking to residents, talking to even just med students who are at different schools. If you're like, I don't know any residents, but maybe I know a med student at Brown, and I can just kind of see like, how do you, think about this program? So I think there's tons of opportunities. Don't get overwhelmed by it. Just take it step by step.
Thank you. And lastly, Dr. Lowery.
Well, I think you've had some great advice. And so I don't necessarily have anything to add, except just take advantage of some of the virtual opportunities. And I think my colleagues have given you some great advice.
Okay, thank you so much. I saw a question in the chat about EMIM. We definitely had an EMIM resident who was going to be in attendance. Unfortunately, she got placed on call, so she is unable to attend. If you have any more questions about that, if you want to reach out to me, I can get you in contact with her, okay? And let's see. Okay, how does Medpedes differ from family medicine? So, of course, Dr. Lowery or Dr. Mora, whichever or both, if you guys want to tag team this, go right ahead.
I will say that our family medicine colleagues are wonderful. I was strongly considering family medicine up until the very end before making the decision to do Medpedes. And so I think some of the biggest things is just the focus on inpatient, outpatient. So family medicine will have a lot more ambulatory or outpatient time. Some will have like the general surgery requirement, obviously some emphasis on OB. And Medpedes will have much more inpatient time, much more ICU time, and less ambulatory, and then a really robust peds experience, which were some of the reasons why I decided to go Medpedes. Even though I still want to have a really lovely career in primary care, I was really looking for that strong pediatric training, and then knew that I wanted to take care of some medically complex patients. And so I was looking forward to the strong inpatient, especially some of the critical care rotations as well.
I definitely agree. I think Medpedes gives you that depth of experience that family medicine does not. The additional fact is that if you so choose to do a fellowship, you definitely have more options with the combined IMPEDS residency. So, yeah, I agree with Dr. Nora.
I think another piece to this is if you are interested in pediatrics, the field of family medicine has a lot less exposure in terms of like the residency program. Of course, if you decide that you want to see more peds patient as a family medicine doc, you can, but it's about 50-50 internal medicine and pediatrics and Medpedes, and that's something that personally I was attracted to in this field. Our next question, did you have mentors in your fields? And how do you suggest we go about finding mentors? And we can go back to Dr. Wright.
Initially, during my third year, I was not well versed in, what med psych actually was. So a lot of the information that I got about it as a career was from consult liaison psychiatrists who also like went to residency programs with people who were dually boarded. And they were the ones who actually recommended that I, get myself linked into the Association of Medicine and Psychiatry, where I found a mentor. And this was a resident in, I believe it was his third year. So his like year of psychiatry, like solely psychiatry clinic. And he was the one that was, a little bit harsh about it, but specifically asking, why consult liaison psychiatry versus med psych, or what could I not be able to do if I were to like just pursue categorical internal medicine. And I think a lot of those questions centered more around like, 5 years from now, well, not 5, but more like 7 years from now and 10 years from now, how do you envision your future and the way that you practice medicine? And what do you need training wise to be able to get there? I think those are questions that like only you can answer yourself. But I think having a mentor, if you're interested in internal medicine psychiatry, that is actually dually boarded, those are the kind of people that can actually help guide you to be able to determine whether or not, categorical psychiatry or categorical internal medicine or like a combined program is the best way to reach the goal that you want.
Thank you. And Doc, what are your thoughts?
I think one of the things as one of my mentors once told me about having mentors, and hopefully you all have heard this before and are using it too, is that, have multiple mentors and be cognizant of the fact that in time you will yourself become a mentor. So specifically, did I have triple board mentors? No. gratefully, I did have friends from undergrad who were in places where triple award programs existed, and they were able to connect me with some of their colleagues and residents and folks that they knew. But I definitely had mentors in pediatrics, and I had mentors in psychiatry, and each of them had their different function. You know, there were some pediatric mentors who were very much so my mentors in research. Others in psychiatry who are my mentors in advocacy or mentors in patient care, and then one who man, Nicodemus Watts, who I respect tremendously. It's from the time I was a pre-med, sat me down and did the whole, this is what it looks like to become a child psychiatrist. Sort of soup to bones, bones to soup type of representation. So it's important to rely on different people for different aspects that sort of feed the different needs that you have, especially with, and I think this is true for most people who are in combined programs, we tend to be dreamers. We tend to want to see the world differently than the way that it is. And so in so doing, it's just important to have people who are trying to catch your vision and catch your wave. So it's good to just be able to grab from your different mentors as you see fit and as needed. And of course, they're always going to be happy to help you. That's the power of a good mentor.
Thank you so much. Dr. Lowery, who are some of your mentors along the way, and how did they affect your path?
Well, I think initially when like I said, I came to medical school thinking I was going to be a pediatrician, and then fell in love with Medpedes. In the first conversation, my mentor at the time said, do you like the learning aspect of internal medicine, or do you like actually taking care of old people? And I said, well, I like taking care of old people, which it's funny to this day because I actually don't take care of really old people anymore. But I did like that learning aspect and taking care of my adults and families. So I think finding mentors, and I agree with Doc when he said, well, first of all, we also have to remember, for those of us on the call, most of your mentors may not look like you. And so we're going to have to be comfortable with seeking mentors in a variety of avenues. The other thing is, I still have mentors today. Some of my mentors are younger than me. Some of my mentors are older than me. But having, like Doc said, mentors in a variety of areas, whether it be research, whether it be your development as a resident, whether it be faculty development, just whether that person you can have that, hey, I had a bad day conversation with. And so I think that's very important. And to develop mentorship throughout your career and throughout your trajectory. And the other thing is, we're in medicine. It's okay to have mentors outside of medicine. Some of my best mentors are actually in like human resources or in business, and they look at things from a different lens and kind of can see things differently than us. So again, you don't want to have like 30 different mentors, but again, mentorship is vital and it's very important. And so, but I also be careful, because sometimes we get so concerned that I don't have any mentors. Your mentors may not look like you, but I agree with someone who said people who are out there are more than willing to mentor you and help you along the way.
Yes, and personally, I've been talked off many a ledge by Dr. Lowery, so thank you so much for that. I believe we have another question coming in. For you, Doc, what makes a strong triple board applicant in your opinion? And what do you think is most important to emphasize in your application?
I think from my experiences, is the coolest thing about triple boarders is that we all have different visions of what our career is going to look like. I think ultimately what makes a person the strongest applicant is someone who can articulate what that vision is. Similar to the question that was asked to Dr. Lowery about, do you just like the learning aspect of it versus do you like actually taking care of these different types of patients? And of course, it's not to say in your end career or you're going to be, taking care of adult schizophrenic patients while taking care of like really complex ADHD or autistic children, and also, tapping joints and doing septic workups on children. You're probably not going to do that level of care for all three, but it is still something to be said for wanting to know that you see a thread and you're trying to follow it through for how you envision taking, if not all three of them, sort of which aspects of the different fields that you plan on borrowing and using for your career. Outside of that, I think the other awesome thing about True Reward is, again, it's a small field. It's 9 programs, 21 spots. So everyone kind of gets to know each other during the interview season. We see each other, we hang out with folks, you get a chance to like chat and just have those relationships. I would say by and large, the stereotype of who are the most chill, laid back physicians are psychiatrists and pediatricians. So you have the two of us together. We as a group of people definitely do love seeing other folks who just, feel good, feel comfortable in themselves. And then also just sort of have a vision for life, and not to say that everything needs to be scripted. That's not what I mean by that, but just like knowing what you want to get out of and use your training for.
Thank you. We have another question. So in terms of reaching out to providers from both specialties, is that, especially I think in this time, what are your opinions about getting letters of rec from every specialty within that combined residency program? I'll start with you, Dr. Nora.
I think this is going to be a frustrating answer, and it depends. So for many Medpedes program, there are some programs that require letters from medicine and pediatric specialty, or like chair letters. Some people that want a Medpedes written letter. And a lot of that can be really unfortunate in the sense that you feel like you have to go to everyone's website and kind of figure out who wants what. I will say the beautiful thing about having an organization like the National Medpedes Resident Association is that they've begun to centralize a lot of the information. And some of those requirements, especially in light of the pandemic and just knowing that people's clerkships got canceled and people weren't able to do all the sub-Is that they wanted to do, they have a website, they're a web page where you can go and find out, okay, what programs are adapting and which ones are taking which letters. And so I think it's upon you to do your good research to actually go in and make sure that you're getting the letters that you need. And if you're having difficulty getting those letters, I think talk to the people at your school and see what else they can do, what other opportunities they can do or provide or create for you so you can have those letters. But if there truly is a program that you're like, look, I don't know if I can meet these letter requirements because of what the pandemic has done, don't be afraid to reach out and kind of explain your situation and see if they have any flexibility as well. Part of going through this process is learning how to be a really good advocate for yourself. And so make sure that you're talking to your school about what you need. And at the end of the day, also talk to the program directors, because if you're interested in a program and you got questions about a letter, don't let the vague, I don't know, keep you from reaching out and keep you from applying to that program. Best thing is just to ask.
Thank you so much. Let's go with Dr. Lowery.
Yeah, I definitely agree, especially with reaching out to the programs that potentially require a letter. I think for most of them, we want to see a letter from your specialty. So if you're going into Medpedes, I want a letter from medicine. I want a letter from peds. And very similarly, if you can get a letter from Medpedes, that's fine. But we also know that a lot of programs don't have Medpedes or the combined specialties that we are in. And like someone said earlier, we are very, very small. And again, all the program directors, they meet once a year. They pretty much all know each other. So again, let the fact that you don't know not dissuade you. But yeah, I look for, when I'm interviewing, I especially look for a strong letter in medicine and peds. The chair letters, everyone gets them, but I'll be honest, a lot of them are just cookie cutter format. I'm not saying you don't need to get them. You still need to get them. But yeah, so I look for a letter personally for me that speaks to the individual, potentially what they can bring to the residency, and their characteristics. And that's the other thing. When you ask for a letter, please make sure the person is a good letter writer and that they can write you a strong letter of recommendation. And so don't just say, oh, would you be willing to write me a letter? but would you be willing to write me a strong letter? And then I like to see, and this is me personally, I like to see an individual's their CV and their personal statement, and I at least have a conversation with the person before I write their letter and ask, hey, is there anything, within your CV or within your letter, in your applications, that you want me to highlight and draw out? So again, because I think that kind of adds a little light and a little personality to the letter.
Thank you. Our next question is, did you dual apply slash, I guess, how to back up specialty? And I guess we'll start with Dr. Wright.
So the Army only has like one med psych program, so that was to my benefit. But in terms of like, I guess, a backup specialty, I guess I was kind of like all over the map. At the time of like application, I was really on the fence. Like, I kind of like both medicine and psychiatry equally. And literally that was like reflected in my application. It seemed like every other program was either like medicine or psychiatry. And really just kind of depended on how I felt about the residency program itself and how I felt about the residents. I think I would have been equally comfortable or happy in either, like, one of my top internal medicine programs or one of my top psychiatry programs. But I certainly ranked them differently based off of how I felt about specific programs.
Thank you. I see that we're kind of drawing to a close here, so I'll ask Doc if he could answer this question as well.
Yes, I did have a second. I do apply to triple board and then just categorical psych in a large part of. But just one thing to think about when you're making your ranking list. You might go into the season thinking I'm gonna just do all of this and I'll rank all of that. But just be open to the experiences that you're having, the conversations that you have with the program directors, with the residents there. Because ultimately, when I made my rank list, it was pretty well interspersed. Brown was my top choice, but right after that was, in fact, 2 and 3 were both categorical psych programs. So just let this season guide you.
Thank you. I think we have another question for Dr. Wright. Why did you choose med psych versus family med psych? And do you know what differences there were between the two?
Personally, I chose internal medicine psychiatry because of the subspecialty options. You cannot get into infectious disease from family medicine. You can be like an HIV provider technically as a family medicine doctor, but you're certainly not doing inpatient infectious disease as a family medicine doctor. As far as like the differences between the two outside of like specialty options, I think like family medicine residency programs tend to have like less inpatient exposure, kind of depending on which program that you're looking at. It's more like outpatient primary care focused for, I'd say, probably a decent majority of the programs. So if you're kind of leaning more towards, having future career prospects in like the subspecialty route, or if you're thinking, I really, really enjoy inpatient medicine more than I enjoy outpatient medicine, or even potentially half and half, I think probably internal medicine is more along the line of what you should be thinking about as opposed to family medicine. If you have no interest in like OB-GYN or like dealing with kids are not my jam. So family medicine was certainly off the table for me.
Sorry, guys. So basically the question is, as a first year, how do you find a mentor if there aren't many people available at your school in that realm? I do want to just throw out there that the SNMA is a great way to connect with physicians all over the nation. We have over 400 chapters. And so if you're interested, please become a member and get what you need. There's also Tour for Diversity, who we've been partnering with, and also has physicians who are alumni of the SNMA as well. Does anybody want to add anything to that?
I will definitely say one of the best things about being a medical student, or even if you're just a pre-med, is just being really proactive about trying to find mentors and not letting one closed door stop you from really being active. I think, like mentioned, SNMA, LMSA, Tour for Diversity. I personally work with Black Girl White Coat to provide mentorship for people who are looking for it. So I think if you are interested in something, the best thing you can do is just talk to as many people as you can, email as many people as you can. Cold emails don't always get read, so don't necessarily take it as a personal thing. As me, like small intern myself, of just like drowning in a bunch of notifications. So it's very possible that people just miss things as well. So I would just say, like, don't be discouraged. Like it takes people time to find a mentoring relationship that works for them. And so keep reaching out. Join organizations like the SNMA because they're going to be really perfect for connecting you to people who have already expressed interest in becoming a mentor.
Thank you. That is a beautiful line of wisdom. And so with that, I want to ask first, Dr. Lowery, if you can provide us another line of wisdom.
Wow. At the end of the day, being able to take care of patients and provide patients, it is definitely, to this day, for me, 20 years into my post-medical school, it's still delightful, it's still an honor, and it's still a privilege. And even doing things like this, it warms my soul. So, and don't worry about being, if you're the only one,
Thank you.
because you'll be okay.
Thank you so much. And how about you, Doc?
I have to say that there have been so many experiences throughout intern year and now as I'm transitioning to my, second year, that I found so much joy and meaning in working with my patients. But I think outside of the work that we do with our patients, it is important, imperative for us to cultivate our own joy, to be able to choose joy. Because there is a lot that's going to be working against it and that's working against us. Residency training is difficult. It can be life-threatening. So I say this to say that find spaces that that you feel well, that you feel happy, and that you feel that you can grow into be the physician that you have been purposed to be.
That is beautiful. And Dr. Wright.
I'd say it's okay to be an odd duck by virtue of you actually being on, this actual meeting. You're probably interested in things that most people are not interested in. And you may get some flack about thinking about things that are not, the norm. But if you can envision it in your own future, that doesn't mean that it's impossible if somebody else can't see it in your future for you.
I just had to snap for that. That was a great one. Well, I want to thank you guys all for joining us and for sharing your knowledge, panelists, and thank you all for watching and interacting and asking all these really good questions. So we appreciate your support of the SNMA and our membership. And for those of you in the audience, please scan the QR code on the screen. It's going to be located in the chat, and also give us some feedback because we want to continue to work to create useful programming for you all. Don't forget the CS campaign, and thank you again for joining us. I encourage you all to follow us on Instagram at SNMA_official, on Twitter at SNMA, and like us on Facebook. But most importantly, if you are not a national member, please visit thesnma.org to sign up and get connected. Especially you fourth-year students, it is even cheaper to get a membership to take you through the rest of your year. Thank you for tuning in, and I look forward to seeing you all at our upcoming Sowing Seeds webinars. Our next one is urology on August 26th. Then we have ENT on September 2nd, followed by ophthalmology on September 9th, all at 8 p.m. Eastern Standard Time. Thank you all for your time.